So I'm just going to give you a quick background that in 2012, you're aware that CDC Atlanta recommended one-time baby boomer screening in addition to risk-based testing. They used a 1945 to 65 age cohort cutoff. Then there was a second Canadian symposium in Victoria in 2013, and at that time, Canadian hepatitis C surveillance data was updated by the Public Health Agency of Canada. The Public Health Agency of Canada then supported a meeting to review the age cohort data, and that was done in October 2013. And they were about to recommend a 1950 to 70 age cohort screening recommendation, and that was supposed to be released in December, and that was held. So the desired state is, of course, a Canadian Hepatitis Strategy or Action Plan. Sharon highlighted how that's been useful for Scotland, but health is provincial in BC, and not only is each province its own island, but in fact each province is its own country, and then there's 3 territories that are additional countries. And fundamentally, to get an action plan going, you need dollars, and dollars are an issue. So in July, there was a presentation to the Council of Chief Medical Health Officers which outlined the need for an expert working group because there was no appetite for an action plan. And then there was a presentation to the Pan-Canadian Public Health Network to place hepatitis C, or at least a working group, on its 2015-2016 work plan. Then there was a meeting of the deputy ministers in December 2014 where there are concerns about the benefits of having a one-time birth cohort screening. And then there was the public release of the PHAC one-time screening recommendation that was withheld. And this was felt to be an opportunity or an impetus for an expert working group to be formed, and then the revised nomenclature was that of a hepatitis C task group. So the suggested terms of reference for such a task group, and this has gone across the country, was to review the Canadian Hep C epidemiology and account for provincial territorial disease burden differences, to review the cost-benefit studies for Canadian applicability, to combine cost-benefit business case, recommending options to the Council of Deputy Ministers, and then to discuss the implications of implementing a screening or testing program as recommended by PHAC or as not yet recommended by PHAC, and its incremental yield relative to prioritizing those individuals already diagnosed. And that's very relevant. Rob highlighted that we estimate that about 70% of the population has been diagnosed. So you have an untreated population, and you know theoretically who those are, versus an undiagnosed population, and that would require a screening program to take place, or at least a testing program to take place. So other components which were recommended to go forward for this task group, terms of reference, was to provide recommendations on which populations to treat, to test and treat and when, and that's clearly a complex issue. How to prioritize the testing, and Rob Myers highlighted approaches that could be used. And so prioritizing testing for various population groups to maximize the cost effectiveness and their health outcomes. And then to also include some phased options for provinces and territories to implement it. And then the other points were to try and summarize the evidence for using treatment as prevention to reduce transmission, onward transmission amongst people who inject drugs. And then finally, to outline some surveillance and program needs. So while this was taking place, those questions that I just mentioned really fit into some of the cascade of care comments that Naveed Janjua mentioned, which is if you're going to create an action plan or you're going to create a response to hepatitis C, you do really want to think across the prevention components, the care engagement components, the diagnostic components, who's on therapy, who to treat first, and that requires one to answer those questions at a really high level so you can go forward. So while those deliberations were taking place, there was this paper that was released online on January 13th, which all of the provinces got a hold of, which said, is widespread screening for hepatitis C justified? So this is very similar to that Sun article on the bad components of HPV vaccine, except this is in peer-reviewed literature, and I'll show you some of the comments that this group highlights and some of the potential responses. So in terms of the response to what Krajden said, he says, his group says, data doesn't support long-term benefit of Hep C screening. Well, this flies in the face of CDC Atlanta and U.S. Preventive Services Task Force recommending one-time screening and testing, as well as risk-based testing. It also flies in the face that majority of the hepatitis C infections are in fact in baby boomers, that maybe many baby boomers don't know in fact that they are infected, and without actually doing screening or testing, more baby boomers would die prematurely from treatable liver disease. The second thing this group highlighted was sustained virological response shouldn't be used as an endpoint. And Mark highlighted this morning that the relapse rate is important. But if you actually look at all of the literature, SVR is widely accepted as the marker for a virological cure. It is supported by every randomized controlled trial and every cohort study. And in a recent meta-analysis by Hill in 2014 shows that if you get to having an SVR, it's associated with a 62 to 84% reduction in deaths, a 68 to 79% reduction in liver cancer, and a 90% reduction in the need for a liver transplant. And that's based on using the older drugs. The group said poor tolerability and toxic side effects, and that clearly is a misrepresentation based on the use of outdated information on older drugs, which were indeed poorly tolerated and had toxic side effects. The new drugs are clearly shorter course, have less side effects, and substantially better cure rates, though you could argue how perfect they are. Then there was the fact that there was a lack of real-world proof of the benefit of these new drugs. Ostensibly, that is correct, but it is completely inconsistent with the peer-reviewed literature that says it is illogical that the outcomes of the newer drugs would be worse than those of the older drugs, which had terrible side effects. Finally, the group said physicians should resist screening until we have strong evidence that antiviral therapy is clinically effective and benefits outweigh the harms. And so in our own BC Hepatitis Testers Cohort, it is very clear at a population level that those individuals who had successful treatment, achieved an SVR, had lifespans very similar to individuals who tested negative for Hep C. However, those who were untreated or failed treatment died approximately 10 years earlier. And that's for a number of reasons, both the effect of the virus and the fact that people acquire Hep C because of risk activities. So in summary, a recommendation for a one-time age cohort screening or testing is evidence-based, based on the worldwide literature, and it's justified on the basis of one's duty to inform. And I think that that has to be separated from the public funding of treatment, which is the payer perspective, which we need to struggle through. But fundamentally, we have an obligation to inform the public that knowing that you're infected gives you an option to get treated. So in terms of the challenges and opportunities, clearly there are significant concerns with regard to the dollars needed to treat the population affected. Hepatitis C curability will not go away. There is a need for a public health approach. Screening and testing is a piece, and this was articulated by Rob Myers, and that essentially addressing the work outlined in the proposed Hep C Task Force terms of reference will help articulate a sensible public health approach if you could actually get these 10 provinces and 3 territories to leave their island nature. Thank you.
Questions?
Who is making the decisions?
It depends which decisions.
About if we should have an expert group, when we will have one, what is the objective of this group, and
so my sense is that you have existing processes within government to make these decisions. Society has to decide, or these governments need to decide, whether the investment is into hepatitis C or other related health issues. And what is clear is that the amount of money required to treat our population is large, and the question is, with the controversies that exist in the literature, how to move the leadership forward is a challenge. And I think Sharon highlighted what worked in Scotland. My own experience is having seen what happened a decade ago in Canada. I don't think we've advanced in our ability. What has advanced is the science of hepatitis C, the curability of hepatitis C, and yet we still have a government that, and many different governments, pockets of government, that really have to embrace what is the best thing to do for their populations.
No, just, so I don't, were you actually involved in the discussions with the assistant deputy ministers when they made this decision to pull the PHAC announcement? Because I guess it's interesting that Cohort's paper actually came out after they made that decision. So I guess I'm a little skeptical that they really went through the evidence that carefully, and the obvious reaction is they just said one-time screening is going to lead to a big cost. And I guess, was there any explanation for why they pulled the announcement, and is there any plan for PHAC to reconsider this with some kind of timeline other than saying they're going to put together an expert task group, which sounds like a delay tactic?
So I'm not aware of the precise details of what caused the pulling back of that announcement. What is clear is that even with CDC's recommendation to do increased screening, that the actual uptake of screening isn't that significant in the United States. Right. And then there's other nuances that in the United States, without the task force's recommendation in the US and the CDC's recommendation, there's no funding for the testing. Whereas in Canada, there is some funding, and probably compared to other jurisdictions, we have screened more of our population. It's also important to realize that the average baby boomer doesn't intersect with the healthcare system in a very systematized way. And even in British Columbia, where we have a centralized human papillomavirus pap smearing program, only 70% of women actually access screening. So implementing a screening program is not trivial, and so that needs to be thought through in terms of making sure that even if you diagnose someone, what's your capacity to treat them, where are they going to get treated, what's the supporting components that they have accessible to them, highlighting all of those points in the care cascade that need to be thought through. And that's some of the challenges that governments face.
Which is all true, but the starting point is to say that screening is a useful thing to do, and it's an evidence-based thing to do, and then you need to put the things in place that make a screening program has to lead to something else. It can't be an endpoint in and of itself, but I guess the idea that we don't have everything in place so we shouldn't take the first step doesn't make a lot of sense to me.
And hence the comments that I think we have a duty to inform. And first and foremost, that's our job, and then trying to explain our duty to inform and create that into a logic model in terms of having someone look at the evidence and think about it logically, not a logic model that you use for delivery, needs to be considered.